All right, well, we just hit the top of the hour, so we're going to go ahead and get started. Good afternoon, everyone, and welcome. Today, we are so excited to be joined by Dr. Sudhir Gupta from the UC Irvine School of Medicine, who joins us to discuss selective IgA and IgM deficiencies. My name is Emma Mertens, and I'm the Program Manager for Education here at the Immune Deficiency Foundation. On behalf of IDF, we thank you for tuning in to this virtual event. IDF Lunch and Learn events explore different types of primary immunodeficiency, providing diagnosis-specific information and support to the PI community. In offering these programs, we aim to move forward in our vision of a healthier day every day for every person living with immune deficiency. Before we get started, a brief disclaimer. Please remember that information presented during this meeting is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational event. And now I'm so pleased to introduce our speaker for today. Dr. Sudhir Gupta is a professor and department chief in the Division of Basic and Clinical Immunology at the UC Irvine School of Medicine. He also serves as the director of the Jeffrey Modell Center for Primary Immunodeficiencies at UCI Health and is editor-in-chief for the Journal of Clinical Immunology. We are so thrilled to have him join us today for a discussion on selective IgA and IgM deficiencies. Welcome, Dr. Gupta.
Thank you, Emma. It's really a pleasure to be here. And just at the outset, I'm not an editor of Journal of Clinical Immunology. Uh, I founded the journal back in 1980 and ran it for 3 decades before it was handed over to Clinical Immunology Society, and now it is much more a independent journal. So uh, uh, currently, I'm not. I'm only the founding editor in chief of Journal of Clinical Immunology. So having said that, now we are going to talk about selective IgA and IgM deficiencies. Let's see if I can. Why it is not moving? It's not progressing. Okay, these are the disclaimer that we all have to give before we give the talk. So I'll give you a very brief one slide of introduction, and then we will discuss the structure and function of IgM, IgA, which will really explain when you have the deficiency, how these disorders are clinically manifested. Will give you more of the prevalence and inheritance, and finally the diagnosis of both these disorders. I'll also summarize for you the similarities and differences among these two conditions, briefly touch on clinical features, and then treatment option, and then some take-home messages for you. So currently, as of end of last year, we have 559 different primary immunodeficiency diseases, and we call them now more appropriately inborn error of immunities because there is an entire group of primary immunodeficiencies, so-called primary immunodeficiencies. They do not have immunodeficiency, they have the excess of the immune system. And that's why slowly, the term of primary immunodeficiency may be changed to inborn error of immunity, and primary immunodeficiencies group will be one of the component. There will be three major component: a primary immunodeficiency disease, a immunodeficiency of immune regulation, and immune defects of autoinflammation. There are now about 520 disease-causing genes. And as you can see in just last 2 years, every 2 years we update this list. So just last 2 years, you can see there are 67 new inborn error of immunity has been added. So it is a very rapidly progressing field, and these disorders will continue to increase. Even though individually these primary immunodeficiencies are rare, when you do collectively, they are almost 1 in 1,300. That puts them as common as multiple sclerosis, about 5 times more common than hemophilia. So you can just think they are not that rare if we have the awareness about these disorders. Among all the immune deficiencies, primary antibody deficiencies are the most common, and they make up about 60 to 70% of all immune deficiency. Selective IgA deficiency is the commonest of the immune deficiency, and selective IgM deficiency is one of the rarest one of the antibody deficiency. So we'll be discussing a very common and a rare type of immune deficiency. So before we go on to the immune deficiency, we should know the structure and function of these two immunoglobulin. So the cell that makes these immunoglobulin is the B cell. And these B cell will differentiate into plasma cell to make antibodies. B cell themselves do not contribute very much to circulating levels of the immunoglobulin. It is their differentiation into the plasmablast and the plasma cell. The plasmablasts are sitting in the lymph node of the spleen, and plasma cells in the bone marrow, they continue to produce those immunoglobulin. So there are 5 classes of immunoglobulin, as you can see here. Uh, and you have IgM, which we'll be discussing, IgA, IgG is IgG is the most common immunoglobulin or maximum amount of immunoglobulin, which is present in serum as well as in the tissues. IgE is associated with a defense against parasites, but associated with allergies. IgD has not very much defense mechanism, but if it is very much increased, it may be associated with certain diseases, but we won't be discussing. But in general, the function of antibodies is to defend ourselves against a variety of bacteria and some of the viruses, because majority of the viruses are defended by our other arm of the immune system, the T cell arm. So here is the structure of the two immunoglobulin that we'll be discussing. If you see here, a one, why it's keep going? Okay. So if you look at here, the one, it is a Y-shaped structure. If you take one of this blue structure, that will be like IgG molecule. So here in IgM, you can just think about 5 molecules of IgG. They have been joined by a chain we call as J chain. So it becomes a very large molecule. So IgM is a, a very big molecule. And if you look at the two arms of the Y, those are the arms where the immunoglobulin or antibodies bind to microbes and neutralize them. So you can imagine IgM has You have two in each arm, so you have five. So you have 10 arms there which can bind. So it is a very powerful one. And that's why this is the first immunoglobulin to be produced when we come across a microbe, because it's very, very efficient way, as opposed to IgG, which will only take care of the two arms. IgA is in the two form, one which is predominantly present in our blood, and that is, if you see here, the monomer, and that's a IgA1, whereas IgA2 is predominantly a secretory IgA or immunoglobulin, where it is just like the two IgG molecules here, they are joined by a secretory component and a J chain. So this secretory component is produced when the IgA is at the mucosal surface. It is produced by the cells of the mucosa. And what it confers is, it confers its resistance to various enzymes. And that's why IgA in the stomach and intestine, it is very resistant. It won't be broken into the pieces. Whereas other immunoglobulin, they will be broken in the pieces, and that's why you cannot give them orally, because they will be with the stomach and intestine enzyme, they will be broken down. So IgM is the first antibody to be produced following exposure to any novel antigens that we are not exposed to. And here the example of microbe, or when first time you get the vaccine, IgM is the first immunoglobulin to produce. It makes about 10% of total immunoglobulin, and it has a half-life of 5 days, as opposed to IgG, which has a half-life of about 4 weeks. And the reason being that the immunoglobulin bind to a cell through a neonatal receptor, and it is recycled. So it prevents the destruction of the immunoglobulin. Therefore, the immunoglobulin that do not bind to this neonatal receptor, they are destroyed much faster. And that's why you will see other immunoglobulin have a shorter half-life. It is predominantly present in blood, so very little in the tissue or secretion. So it is almost exclusively present in circulating blood. It has a very important defensive role against viruses, bacteria, fungi, and protozoa, but predominantly the bacteria, but definitely other microbes also. It has also a very important role in preventing the autoimmunity. That means our immune system, it doesn't allow or prevent our immune system to react to our own tissues, and therefore it prevents the immunity. And just keep this in mind. And then it is an anti-inflammatory. So keeping this in mind, these are the function. So if you have the deficiency of IgM, you just flip everything. They won't defend us against microbes. Now they will start reacting to ourselves, and they will be more inflammatory. So the manifestation that you are going to see is based on what their functions are. IgA, as I showed you, it is present as a monomer, a single molecule, or joined with a joining chain as a secretory piece. It is present predominantly as secretory immunoglobulin, is present predominantly in the mucous membrane, mainly a respiratory tract, gastrointestinal tract, and genitourinary tract. It is found in saliva, tears, and breast milk. So it is a very, very important molecule in transferring in a neonatal period a passive immunity from mother to the newborn. As I told you that secretory piece confer a resistant to proteolytic degradation. So the enzyme in the stomach and intestine cannot destroy it. Again, it has a very short half-life, just like IgM, because it also doesn't bind to that neonatal receptor. And there's a minor difference in the half-life of between IgA 1 and 2, which doesn't seem to have much of the clinical significance. So the functions of IgA, again, it neutralizes the microbes, the pathogen, or their toxin. It also, since it is on the secretory surfaces, so in the gastrointestinal tract and respiratory tract, it blocks the attachment of those microbes, the bacteria and the viruses, to the mucosal surfaces. Therefore, they cannot gain entry. As I said, since it is present in colostrum and milk, so it provides a neonatal passive immunity. It is also anti-inflammatory, and it is a very important immunoglobulin antibody, which has a good relationship with our healthy bacteria in our gut. So let's look at some of the inheritance and the definition, how we define and what's the criteria of diagnosing selective IgM and IgA deficiencies. So first, let's take the IgM. As I alluded to, it is a rare primary immunodeficiency disease as we know today. It may not be. Selective IgM deficiency was first described in 1967 by Professor Hobb, and we never paid attention to it until 2014 when we wrote an article with a title that it was a ignored primary immunodeficiency diseases. So International Union of Immunological Society, which incorporate all these immunodeficiency, in 2017 for the first time recognized and included selective IgM deficiency as one of the primary immunodeficiency diseases. So by definition, it is a very, very recently incorporated primary immunodeficiency disease, although we knew about it for a long time. There is no definite inheritance pattern. There are few familial cases, but I think as the awareness now, since it has been incorporated as a bona fide primary immunodeficiency diseases, I think these inheritance pattern or the familial cases will be many more. Currently, we have 4 generations of patient with primary immunodeficiency diseases, which we are investigating it. Currently, the gene or genes responsible for selective IgM deficiency is not known. Again, it may not be too long because when we have big families, it provides us the opportunity to discover those genes. So it may not be too long before we may have at least genes for some of the patient with selective IgM deficiency. Rarely it progresses to chronic common variable immunodeficiency diseases. We published one case. Since then, we have 3 more cases in which after 4 or 5 years of follow-up, they have progressed to common variable immunodeficiency diseases. But currently, it appears to be a rare event. Again, the number of cases so far diagnosed with selective IgM deficiency is small, and therefore, again, it may not be that rare, but again, time will tell us. There's no geographic or ethnic differences. So you can go around the world. It is pretty much similar that you find selective IgM deficiency. How we diagnose selective IgM deficiency? There's no definite levels of IgM that has been designated as a requirement. It should be a reproducible low level of serum IgM that are 2 standard deviation below the mean for the age match healthy controls with normal total IgG and IgA. So reproducible is very important. So there should not be, because you will see in the literature, some will give 0, some will give less than 20. So there's no definite number, at least for now. And also equally important is that we have excluded secondary causes of low IgM, as well as there are a number of other primary immunodeficiency diseases in which there is a low IgM. So those have been excluded. Then you make the diagnosis of primary selective IgM deficiency. So what are the causes of secondary selective IgM deficiency? They are diseases and they are drugs. Diseases most common are the lymphoid malignancies, that means lymphomas and leukemias, and chronic lymphocytic leukemia and non-Hodgkin B-cell lymphomas. There are certain chromosomal abnormalities that are associated with selective IgM deficiency. And as I alluded to, there are certain primary immunodeficiency diseases or inborn error of immunity. They have low IgM as well. So the drugs you see there, we can divide them into 2 categories. One are psychotropic or anti-epileptic drug. And what is known are those 2 drugs that I have listed there. We do not know whether there will be additional drugs which over a period of time will induce a selective IgM deficiency. A B-cell depletion therapy, as you might know, these are the treatment which are more and more commonly now used with in variety of autoimmune diseases to get rid of the B cell which are making autoantibodies, the bad antibodies. But unfortunately, we do not have the technique or the molecules that can selectively eliminate the B cells that are producing bad antibodies from the good antibodies. And therefore, these treatments are associated with decrease in immunoglobulin because you are removing those B cells. And it appears the IgM, selective IgM deficiency may be more common and earlier as the treatment continues and those cells are removed for a longer period of time. We see the immunoglobulin of all the classes to be down. So so So, as far as selective IgA deficiency is concerned, it is the commonest primary immunodeficiency in North America and Europe in Caucasian population. It is as common, it's more common than any of the common diseases even. It is 1 in 500 of the population who have selective IgA deficiency, but it has a geographic and ethnic differences. So if you go in Asian countries, take the example of Japan, it is 1 in 15,000. In India is 1 in 6,000. So it has the differences. Whether those differences are as a result of some of the genetic changes or genetic HLA association, we do not know, but we definitely know that there are geographic and ethnic differences with regard to selective IgA deficiency. It can be spontaneously or sporadic, or it could be autosomal recessive or dominant. It appears to be inherited, and therefore, in the families, you have much higher frequency of or prevalence of selective IgA deficiency, as much as 20%. How we define selective IgA deficiency, there we have a very precise number, and that is below 7 milligram per deciliter. And why it is not below 5? Because the method that we measure, it can measure only up to 7 milligrams. So it doesn't measure below 7 milligrams. So basically, what it means is IgA is undetectable. And again, in this case, you have to have IgG normal and IgM normal. And you always diagnose this. Don't diagnose selective IgA deficiency in less than 4 years of age. The reason being because IgA develop or mature very slowly. So you can have some children where it is maturing little slow, but it will catch up. So the adult level of serum IgA reaches around 11 years of age. So it is very, very important that to keep in mind that if somebody has low IgA, less than 4 years of age, just wait before you make them to diagnose with selective IgA. Just like IgM, you have to exclude the causes of low selective IgA. Uh, if you look at the inheritance we talk about and the genetic, we don't know the genetic in selective IgM, but in a subset of selective IgA deficiency, there's a particular gene. This is a touch gene, which is at least mutated. So there is a defect of the gene. And interestingly, this gene is also one of the commonest known gene in patients with common variable immunodeficiency diseases. And therefore, you can think about it within the family of selective IgM deficiency or CVID. You can have some of the patient in selective IgA deficiency, some member could be CVID or vice versa. Not that they have to be necessarily, but the prevalence become little much more because you see a common, and common when we say in CVID, you have only 20 to 30% of the cases we know the genes responsible for it, and out of that, Tachi is the commonest one. So as you can see, so there is some similarity or some genetic basis shared between the two diseases. And therefore, you will think patient with selective IgA deficiency may also progress to common variable immunodeficiency diseases. Then you see there is an association of some of the HLA type here. HLA-B8, here you see GQ2, and these are the susceptible HLA type in the people who develop autoimmune diseases. So IgA patient, again, you increase the susceptibility to autoimmune diseases. And if you look at the DQ2, this is one of uh, this is one of the HLA type which we always test when we are suspecting celiac disease. So again, you can think about it in patient with selective IgA deficiency, the celiac disease would be one of the common autoimmune diseases. So the causes of the secondary IgA deficiency, They are again, just like IgM, there are certain diseases that where you can have selective IgA deficiency, and there are certain chromosomal abnormalities which are different from those chromosomal abnormalities that you see in selective IgM deficiency. And there are a number of drugs. Again, some of the psychotropic drugs or anti-epileptic drugs, again, can cause a selective IgA deficiency. And some of those can cause selective IgM, and therefore some of those drugs can cause more than two immunoglobulin, and therefore they can give sometime a picture of CVID. So one has to keep in mind, and we as a doctor, we have to take a good history of the patient before we diagnose those primary immunodeficiency disease. That patient doesn't have any or being treated with any of these medications which can give rise to selective deficiency of IgM or IgA. So there are similarities between the two, as you can see. Majority, 50, 60% of these patients are asymptomatic. They don't even know that they have the disease. Those who have the symptoms, infections are the most common in both these deficiency. Autoimmunity is common in both of them. Allergic diseases are common in both of them. And association of with some IgG subclasses. It is observed in both, even though the total IgG is perfectly normal, but they can have a subset of these patients can have a decrease in IgG subclasses. In selective IgA deficiency, there appears to be some preferential deficiency of IgG subclass, and that is IgG2 subclass deficiency is more often seen than other IgG subclasses, as opposed to selective IgM deficiency. There is no such preference. Usually the T cell numbers, function, natural killer cells, they are all pretty much preserved in both of them. And then these are the two drugs I have listed here. These drugs can cause both IgA deficiency or IgM, or together both of them, one more than others. So there are certain drugs which can give you both a decrease in IgA as well as IgM. There are differences between the two of these diseases. Selective IgA deficiency, as I told you, very common. We do not know really the prevalence of selective IgM deficiency. This only comes from the blood bank donors from Iran. There's only one study. So we don't know really as good the data as we have in selective IgA deficiency for the prevalence. The specific response to the vaccines are very well preserved in selective IgA deficiency. Selective IgM deficiency, about one third of the patients seems to have impaired response, and it is a impaired response to IgG type of antibodies. If you immunize them with pneumococcal vaccine, they have about one third of them have impaired response, and what we are measuring is IgG antibody. So even though low IgM, but they can have a functional defect in IgG. Celiac disease is pretty common among the autoimmune diseases. In selective IgA deficiency, it is rare. It is rare, especially in children. It's extremely rare. And as they age, you can see a few of the older patients having a celiac disease, but it's not a common one. Among malignancies, in IgA deficiency patient, lymphomas of intestine are common malignancies when you see the malignancies. Whereas in selective IgM deficiency, we just don't have any idea about whether there is really increased prevalence of malignancy, because number of cases so far which have been diagnosed and reported is small. Immunoglobulin therapy in selective IgA deficiency is completely contraindicated with a few exceptions, which we'll come back to, whereas immunoglobulin therapy in those patients who have recurrent infections, who have poor response to the vaccine, that means the quality of IgG vaccine antibodies is not good, their immunoglobulin therapy has been helpful. I already talked to you about geographical differences, familial and progression. There is more progression and the familial presence of CVID in selective IgA deficiency, it rarely in IgM deficiency. So let's look at quickly the clinical presentation. As I said, in selective IgM deficiency, those who are symptomatic, majority of them will present recurrent infection, but allergic diseases and autoimmune diseases are also common in about 30% of these cases. Among the infection, upper respiratory and lower respiratory tract infection are the most common one. And allergic diseases, they could have the rhinitis, the hay fever, asthma, atopic dermatitis, and angioedema. And if you look at the autoimmunity, autoimmune diseases, endocrine system, connective tissue are the two commonest one. And if you look in endocrine, Hashimoto's thyroiditis is the most common one. Then in systemic type of autoimmunity, it is the lupus. And then we have so-called ITP and hemolytic anemia. Those are the commonest. As you can see, the GI autoimmunity is not that common. And there are a number of these malignancies have been reported, but these are very individual cases. So we cannot say that there is a real increase in the prevalence of these. Let's look at the IgA. In this, IgA again, similarly, majority of the cases could be asymptomatic, and those symptomatic, again, the infection is the most common one, allergic diseases, autoimmune diseases. Here we see the malignancies definitely is more prevalent. 3 to 5% of these patients may develop malignancies. Infection, again, the respiratory infection, as you would expect, because it is a secretory immunoglobulin, and also the GI infection, and Giardia being the most common one. And whenever you see the fungal infection are common, but they are, as you can see, they are of the mucosal surfaces, the esophagitis or mucocutaneous candidiasis. So a very different. Respiratory is very similar, but other are different from selective IgM deficiency. Uh, if you look at the allergies are quite common, but one of the allergies, the food allergies, which you don't see very much with selective IgM deficiency, is fairly common with patient with selective IgA deficiency. And when you look at the autoimmune diseases, again, you see the autoimmune diseases. It is the GI autoimmune disease, the Crohn's disease, the ulcerative colitis, celiac disease, and then rheumatoid arthritis and another. Even though all different autoimmunities are very similar, but the frequency of those autoimmune disease is very different between selective IgA deficiency and IgM deficiency. Malignancies, as I said, the lymphomas, non-Hodgkin lymphomas are the commonest of the malignancy in selective IgA deficiency. And then the adenocarcinoma, the stomach, especially in the older folks, is common. let's look at the last part as the therapeutic options in both of them. So in selective IgM deficiency, whenever you have a patient with antibody deficiency, the most important thing you have to remember, because these patients, the red flag is always that the patient get treated with antibiotic, they get better, then they come back after a month or after weeks. So it is a recurrent problem, which suggests that the usual course of the antibiotic is not sufficient enough to clear the infection. So they have an impaired response to the antibiotic. And therefore, it is important that the antibiotic use should be used appropriate, but should be a prolonged course. What I usually recommend is to take the twice the course of the. So if you are taking 10 days, uh, take about 3 weeks, 20 days, or you have one Z pack, take two Z pack. And because if you don't get rid of infection completely, you'll be keep coming back. As far as immunoglobulin treatment, there is no consensus regarding immunoglobulin treatment in selective IgM deficiency. Perhaps we have the most experience in this because we have one of the largest collection of these patients, and we have treated selectively those patients who are symptomatic, who are getting recurrent infection, and who have a impaired response to the vaccine challenge. That means, in a layman term, they don't have a good quality of IgG antibodies. So by giving immunoglobulin, you are providing a good quality of antibodies, and they respond well. The severity and the frequency of the infection is markedly decreased, and this is all published. Now, as you can think, IgM would be the most ideal immunoglobulin. Remember, it is very important in autoimmunity. So the deficiency, the patient get autoimmune diseases. So if you have IgM enrich, it could be both from a defense point of view as well as autoimmunity point of view, could be a great, great molecule. And it has been shown, at least in the test tube, that you can prevent the binding of those autoantibodies to the target tissue and in vivo in mice. And these are the mice who have no immune system, and you can populate with human immune system, and they are the model of autoimmune diseases. And in these cases, by giving IgM, you can prevent those autoimmune diseases. So there is a rationale in mice. There is evidence that it could be very useful. And there is in Europe a IgM enrich preparation. It's called pentaglobulin, and it has been used not really from a selective IgM deficiency point of view, from only preventing the infections or in autoimmunity. Lastly, in therapeutic option in selective IgA deficiency, here the awareness and education is very, very important. That you want to prevent, because since they don't have IgA in the system, they are born without it. So if you give any blood product, including immunoglobulin, which contain traces of IgA, it will be like foreign to our immune system. And in those patients, they can make antibodies to IgA molecule and therefore can give an anaphylactic type of reaction. So that's very, very important to understand and to know. And all these patients should wear a medical alert bracelet with their diagnosis and writing that blood or blood product, if ever blood is needed, it should be the washed, packed red blood cells. And all the blood banks do carry that. And again, just like others, a prophylactic antibiotic or prolonged antibiotic, especially in children, it is more commonly used as a prophylactic antibiotic. In adults, we usually do not use a prophylactic antibiotic, but we definitely use for a prolonged period of time. IgA enriched preparation will be ideal, but again, as I said, IgA can produce an anaphylactic reaction, so it is contraindicated. If you have a slightly low IgA, there you can give if those have the infection. So it is a complete lack of IgA where it is totally contraindicated. So a few subjects where you have a recurrent infection, they have selective IgA deficiency along with IgG subclass deficiency. There one can use immunoglobulin with very much cautious. They should use the subcutaneous because we have so far not seen in patients with common variable immunodeficiency who has no IgA, any anaphylactic reaction with subcutaneous immunoglobulin. And secondly, we have to use a preparation which has really almost traces or almost barely detectable level of IgA, and there are one preparation which is available. So a last word about, because you may have the question, the probiotics are good. They may help to compensate the deficiency of selective IgA by enhancing the antibody of IgM and IgG class. They can also correct those leaky, the gap between the epithelium of the gut mucosa. So the leaky gut, so it can repair that also. They can reduce the infection, reduce the mucosal inflammation. But again, the clinical evidence is still limited, but I don't see there is any downside of it, but there are more studies to be done. So take-home message is that they represent the commonest and rare immune deficiency. Majority of the subjects are asymptomatic. They present very similar clinical features, and infections are most common. Allergic and autoimmune diseases are more prevalent. These patients should be followed periodically for any progression to CVID. So very, very important for physician to know that these patients should be followed. And both pose challenges for the treatment option. Again, awareness and education is important. Prolonged and occasionally prophylactic antibiotic use is very much indicated in symptomatic cases. And disease-causing genes are yet to be discovered. So these are your and Jeffrey Modell Foundation, their website, JMF, the IDF, and for physicians, those are key publications for both selective IgA deficiency and selective IgM deficiency. So I'm done with my time. Thank you for your attention, and I'll be happy now to answer any questions.
Thank you so much, Dr. Gupta. That was incredible. You did such an awesome job of breaking down each diagnosis and sharing the similarities and the differences. We've gotten some comments in the Q&A that they really appreciate your approach. So thank you so much. All right, everybody. So we are now going to break for a brief Q&A. We have about 10 minutes left in the program, so we'll work our way through as many questions as we can with Dr. Gupta. And I just want to draw everyone's attention to the chat where we have shared the Q&A ground rules. If everyone could respect those, we would greatly appreciate it. And now Dr. Gupta will go ahead and we will get into the Q&A. All right, our first question. So this individual shared, they said, thank you. This is very informative and you are explaining in a very easy to understand manner. So thank you, Dr. Gupta. This person asks, what is the clinical name for selective IgA antibody positive when a person also has CVID, since in CVID, all the levels are low and not normal?
Right. As far as you are asking the question about IgA antibodies,
They want to know the clinical name for selective IgA antibody positive when a person also has CVID.
you cannot, when you have CVID, the most common combination of the low immunoglobulin in CVID is low G and low A, and it may be completely absent even. So that diagnosis will remain as a CVID. To diagnose or to level a patient with selective IgA deficiency, your IgM and IgG have to be normal. If they are normal, that's not CVID. So that's only selective IgA.
Thank you so much for clarifying. Oops. All right, our next question. Let's see. How do we measure the mucous membrane bound IgA levels?
That is not possible. So, number one, even leave on the bound one, even in the secretion, you will see some of the laboratories do the secretory IgA, which is not really a true or IgA levels that you will get because you have to collect it very carefully. And usually, what we used to do in old days, it was very labor intensive. You put a Kirby cup in your mouth, inside the mouth, and so your saliva will be collecting through the tube, and you take that, and when you measure it, then you have to recalculate as that amount of IgA per gram of total protein. That gives you the actual one. So it is as currently available, it is really worthless. It will give you a very wrong information that your secretory IgA is low. So it should not be done as we have the technology available.
Thank you, Dr. Gupta. All right, this next question. This individual asks, when giving IVIG to patients, given the prevalence of IgA deficiency, is it important to test for serum IgA levels before administering gamma globulin?
Always, whenever you are going to give immunoglobulin, IVIG or subcutaneous immunoglobulin, you have to know why are you giving it. So you have to do the immunoglobulin levels for all the three immunoglobulins. So you will do IgG, IgM, and IgA. Don't give immunoglobulin without doing immunoglobulin because, as you know, IgA deficiency is so common and more than half of the patients are asymptomatic.
Thank you, Dr. Gupta. All right, next question. I know earlier you touched on sort of what are the differences between selective IgA deficiency, selective IgM deficiency. Can you also talk a little bit about how these two compare to a diagnosis like CVID?
Yeah, CVID diagnosis is a laboratory diagnosis. Originally, we had a clinical diagnosis that somebody with a recurrent infection, and then you have to have a laboratory component that in that laboratory component, your IgG has to be low, always. That's one. In addition to that, you have to have one other immunoglobulin low, whether it is IgA or IgM. That's the minimum. You can have all three low. And when you look at all the patient, the combination which is most common is low G and low A. Okay? The second component of the diagnosis is your poor response to the vaccine. And one of the vaccine that we really take the criteria is your pneumococcal 23 vaccine, not the Prevnar 20s, because those are conjugated vaccines. And for conjugated vaccines to be impaired, your T cell system should be also defective because conjugated vaccines take the help of the T cell. So you can just think about it. You're testing the B cell being the horse, the T cell being the jockey. So if you use the 23, it is just telling the horse to run. And if horse is slow, it will show up. However, with other vaccine, which are all other vaccine, which are conjugated, they use the help of the jockeys. So when the jockey gives the kick, even that slow horse start running. So you don't know that that horse was weak. So the very important vaccine for our diagnostic purposes is that pneumococcal 23. So if you are a doctor or anybody, if you have used the Prevnar 20 or 13, and if you have a normal response, you cannot interpret those results. If they are impaired, then it's fine.
Thank you so much. And that's a great analogy. I like that a lot. All right, we have time for a few more questions. Dr. Gupta, in your talk, you spoke about how different medications are associated with selective IgA and IgM deficiencies. This individual asks, what are the recommendations for use of rituximab in patients with IgA deficiency since rituximab is B-cell depleting?
Yeah, you have to always look at from the point of view the benefit and risk ratio. Anything you do, you have to look at. So here you have the autoimmune disease that you want to get rid of that, or improve on that disease. So that's your primary thing. So you're going to use the Rituxan, and what will happen is Rituxan, and there are no data, but as far as from a scientific point of view, if you have a patient with selective IgA deficiency, and now you are using Rituxan, you have removed all the B cells that way, and if you do the immunoglobulin, it takes quite a long time before you reduce the immunoglobulin. So they don't require the immunoglobulin replacement right away or within a month or within 6 months. It takes a longer time of those treatment effect. If they get to the point that all the three immunoglobulins are very low, it is very, very likely the IgE immunoglobulin, you can also look at it, which is important in anaphylaxis. If those are all low, and if patient developing infection, then carefully you can still use the immunoglobulin treatment. Always remember one thing, and this should be for everybody, every physician, every immunologist, that you treat a patient and not the laboratory test. So if patient has low immunoglobulin, you need not to treat them with immunoglobulin, because it is not reflecting clinically that patient is getting the infection. So unless they get infection, you just watch them carefully. Is
All
that the
right.
answer? Yeah.
Yes, yes, thank you so much. All right, out of respect for your time, I know we still have a bunch more questions to get through. I'm gonna close on this last question and I'm gonna combine a couple of them. So this attendee shared, thank you so much. This has helped me greatly understand my diagnosis. Do you foresee any advancements to treatment for patients with selective IgM deficiency beyond IVIG every 3 weeks? And then similarly, a few other folks have asked about clinical trials for selective IgA and IgM.
Uh, as far as the treatment, I don't think we'll have the treatment for selective IgA deficiency in a true sense because of that possibility of a life-threatening side effect. If somebody is low, so if we can put in parentheses a partial IgA deficiency, I think in those cases, if we have really a good IgA enriched preparation, it could be very, very good. Historically, I can always give you very big histories to the back, back in late 60s, Martha Eibel she prepared the IgA-enriched preparation, and she gave for the rotavirus orally, because as you can imagine, these preparations, they are resistant to proteolytic digestion, so they could be. So it was helpful, but you can imagine this was done almost, 60 years back. So I think it is possible in partial deficiency, in symptomatic IgA deficiency, that you could treat them. And this is something which I at least advocate to these companies, that you throw away when you prepare IgG, you should make some IgM enriched preparation and IgA. And I think it might be just a financial thing. But IgM deficiency, I definitely feel that it will be, and since it is available in Europe, why can't we make it? And it was just, again, as now the disease has been incorporated and awareness from last 7 years or so, we are going to see many, many more cases. And then I think perhaps these pharmaceutical company, it will become a financially viable option. But I very strongly feel that IgM enriched preparation would be really a good option for the treatment for patients with selective IgM deficiency.
All right. Well, thank you so much, Dr. Gupta. With that, we're going to move on from the Q&A. I just have a few more slides to share regarding some resources and some upcoming events. Dr. Gupta, we want to thank you so much for your time this afternoon. This was an incredible talk. It was so easy to understand and follow along with. And to our audience, I apologize we weren't able to get to everyone's questions, but we are going to share some options for you to submit your questions here in just a moment. So Dr. Gupta, I know out in California, your day is just getting started, so we'll let you go, but just want to say thank you so much. This was incredible.
My pleasure. My pleasure.
Thank you, Dr. Gupta.
Bye.
Bye. All right, to our audience, primaryimmune.org is going to be your go-to website for additional resources, upcoming events, and more. All IDF materials are free to access, print, or have mailed directly to your home. Again, I know we had a bunch of questions that we didn't have time for today. So if we didn't get to your question during the program, you can contact our board certified patient navigator through our Ask IDF program. She will personally connect with you to tackle your question and to direct you to appropriate resources. You can even take IDF on the road with our engaging podcast series. You can find programs like Bold Conversations, Undiagnosed, and Chronic 20s by searching for the IDF podcast. We also have a YouTube channel where you can find recordings from all of our digital education activities. And we had quite a few folks asking where the recording will be available and when. It will be uploaded to the IDF website and YouTube channel here in the next couple of weeks. And we'll also include the slides, so you'll be able to check those out as well. Walk for PI season is upon us. Did you know that the Walk for PI fully funds our IDF research grant program? Gather your family and friends and start a walk team to be part of the impact. By participating, you are making PI research possible and helping to improve the lives of those impacted by primary immune deficiency. For more information, visit walkforpi.org. Find a safe and supportive environment to link up with others impacted by PI through our Get Connected groups. These groups are free, virtual, and volunteer-led opportunities to connect with others with PI all over the US. We offer location-based groups, so in your city or state. We also have diagnosis-specific groups and nationwide groups. And because the groups meet virtually, you can join any group that works for you and your schedule. Check out the IDF calendar of events to see if there's a group that might interest you. And in addition to our Get Connected groups, we also offer facilitated support groups for young adults, parents, spouses, and partners, as well as a peer support program if you're looking to connect with someone one-on-one. Here at IDF, we are proud to offer digital education each month and various in-person events throughout the year. We have some great programs coming up this fall, and we hope to see you there. And with that, we're going to wrap up today's Lunch and Learn. Thank you again, everyone, for joining us this afternoon. We are so grateful for your participation. And again, we hope to see you back for some more great programming this fall. A huge thank you again to Dr. Gupta for leading this talk and sharing his time and expertise with our community. I have a few links I'm going to drop in the chat, so I'm going to leave the Zoom platform up for just a few moments in case anyone would like to check out those links. But in the meantime, take care. Thank you for joining us and enjoy the rest of your day.